Good morning or good afternoon. I am Alice-Hadchouel-Duvergé. I am a pediatric pulmonologist working in Necker-Enfants-Malades Hospital in Paris, and today I will talk about lung involvement in connective tissue disease in children. Pulmonary involvement in childhood connective tissue disease is multiple and variable. It can be interstitial lung disease, which is the main disorder in connective tissue disease, both in adults and children. It can be intra-alveolar hemorrhage, pleural effusion, respiratory muscle disorder, and also pulmonary hypertension or aspiration pneumonia. The frequency and the severity of these lung disorders are variable depending on the disease. Those manifestations are rarely inaugural. They rarely reveal the disease. They may be acute or chronic. They are often initially asymptomatic, but sometimes they can be very noisy and life-threatening. First, we are going to talk about lung involvement in systemic sclerosis. Systemic sclerosis is a very rare disease in children, but the respiratory involvement is frequent and often severe. There are three main types of respiratory involvement: interstitial lung disease, which is usually a chronic interstitial lung disease with fibrosing evolution; pulmonary hypertension. It can be either a primitive pulmonary hypertension or secondary to hypoxemia. And the third complication is aspiration pneumonia, secondary to the esophageal disorder that often exists in systemic sclerosis. Those complications are often severe, and the cardiorespiratory involvement in systemic sclerosis is the main cause of death. In myositis, the lung involvement may be interstitial lung disease, which can be either a fibrosing non-specific interstitial pneumonia or an organizing pneumonia. Myositis as systemic sclerosis can also be complicated by aspiration pneumonia in the case of swallowing disorders related to pharyngeal muscle damage. It's very rare in children. The muscle weakness may involve respiratory muscles and lead to hypoventilation with dyspnea. Myositis can also be associated with pulmonary hypertension. And in adults, there is diagnostic and prognostic values of the autoimmune profiles, but it's not really the case in children. Antisynthetase autoantibodies in adults are associated with a high rate of respiratory impairment, 80% according to the different series in adults. Clinically, this phenotype is associated with mechanic ends, muscular damage, arthralgia, and Raynaud's phenomenon. And on the other end, the positivity of anti-MDA5 autoantibodies is associated with a severe and usually rapidly progressive interstitial lung disease in adults. And with the lesser extent, anti-KIAU, anti-PMSCL, and anti-RO52 are also associated with a high frequency of interstitial lung disease. In these settings, the phenotype mainly concerns the skin and the lung with skin ulcers, and the respiratory impairment concern up to 90% of the patients, depending on the series. Dermatomyositis can be revealed by an acute interstitial lung disease, which may be rapidly life-threatening, and I will show you one case report. It was the case of a 17-year-old previously healthy Taiwanese girl, which presented with syncope on the background of 1 month of muscle weakness, polyarthritis, and heliotrope. At diagnosis, she had high CPK levels, myositis on MRI, and MDA5 autoantibodies positive. She did not improve with the first-line treatment, which were oral steroids and methotrexate. Then the second line of treatment was pulse methylprednisolone and cyclophosphamide, but she did not improve either. And 6 weeks later, she developed cough, progressive dyspnea with hypoxemia, and acute fever. Her chest CT scan was not normal. She had BIL to exclude an infection which showed Staphylococcus aureus and Myositis girovisi. She was treated with meropenem and Bactrim, but did not improve as well. And finally, because she was depending on 24 hours invasive ventilation. She underwent a tracheostomy. She had a short line of immunosuppressive treatment with IV immunoglobulin, cyclophosphamide, prednisone, and rituximab, but she did not improve. And because she required a full-time ventilatory support with no improvement on any of the treatment that she received, she rapidly underwent lung transplantation 4 months after the diagnosis of juvenile dermatomyositis, with a favorable course at 6 months of evolution. Regarding systemic lupus erythematosus, the respiratory involvement in children is highly variable depending on the series, from 5 to 67%. The lung involvement may be pleuritis and pleural effusion, acute lupus pneumonia, shrinking lung syndrome, intra-alveolar hemorrhage, interstitial lung disease, pulmonary hypertension, pulmonary embolism, and there is also an increased risk of infection. With Elise Bernard and Isabelle Melki, we studied a French multi-center cohort with a retrospective study. 375 patients with systemic lupus erythematosus were included, and 10% of the patients had a pulmonary involvement, that is to say 38 patients. Among those patients, pleuritis was the most frequent manifestation, because it's affected 39% of the patients with respiratory involvement in the cohort. This manifestation is usually revealed with a chest pain. The pleuritis is usually mild, and anti-nuclear autoantibodies are positive in the effusion. The second manifestation is acute lupus pneumonia, that concerned 22% of the patients of the French cohort. The clinical presentation is one of acute respiratory infection with cough, dyspnea, pleuritic pain, hypoxemia, and fever, with non-specific consolidation on the chest CT. The third manifestation in terms of frequency was chronic interstitial lung disease that affected 13% of the patients with chronic CO and exertional dyspnea. The shrinking lung syndrome affected 9% of the patients. This syndrome is related to a dysfunction of the diaphragm, which will lead to a progressive dyspnea and chest pain. The chest CT showed no interstitial lung disease, but a decrease in lung volume with an ascension of the diaphragm and basal atelectasis. The diagnosis is confirmed by the assessment of the diaphragmatic function, which is not really easy to perform. The best exam is nowadays the realization of a diaphragmatic MRI. The other possible investigations are diaphragmatic ultrasound and also electromyographic studies. The other manifestation of systemic lupus erythematosus is intra-alveolar hemorrhage. This complication affected 22% of the French cohort, which is quite frequent. The diagnosis is made with the following clinical presentation, which is an acute respiratory distress associated with anemia. Hemoptysis is not constant. The chest CT scan will be very suggestive with patchy granulous opacities, and the positive diagnosis is made on the examination of the bronchoalveolar lavage fluid, which show a positive gold score over 100 or more than 20% of siderophage. Siderophage are macrophages that stain positive with the purse staining that stain iron, which come from the destruction of red cells. Let's go on now and talk about the treatments and care of connective tissue disease lung involvement. There are two main different settings, acute and chronic. Acute manifestation, like we just say, like intra-alveolar hemorrhage or acute pneumonitis in lupus or in dermatomyositis, may be life-threatening. So this is a therapeutic emergency. And so we will talk about the treatment of intra-alveolar hemorrhage, infection, and acute interstitial lung disease. And the other setting is chronic. The first thing is to determine if the chronic involvement, which is in the most frequent case, interstitial lung disease, is to determine if the lung disease is symptomatic or asymptomatic. One should always keep in mind the risk of the pulmonary fibrosis, and the management is global. The physician needs to assess the impact of the interstitial lung disease on lung function, daily life activities, quality of life, to determine the involvement of the interstitial lung disease in those alterations, because in connective tissue disease there are other involvement that may have an impact of on daily life activity, quality of life, like the muscular or joint involvement, and to prevent and slow down lung function decline and progression to fibrosis. To this aim, we have several supports to rely on, the French guidelines and the international guidelines, and also the multidisciplinary consultation meeting. Regarding intra-alveolar hemorrhage, which is a life-threatening complication of systemic lupus erythematosus, the first treatment is symptomatic with oxygen and ventilatory support when needed, transfusion if needed, and close monitoring in intensive care unit. The first-line medications are high-dose IV steroid pulses, and if the intra-alveolar hemorrhage is life-threatening, IV high-dose steroids must be associated with other immunosuppressive treatment like preferentially cyclophosphamide or plasma exchange. For prevention of relapse, a maintenance treatment must be prescribed. Usually it relies on oral steroids with a very slowly progressive decrease, and oral steroids are usually associated with another immunosuppressive long-term treatment like hydroxychloroquine, azathioprine or MMF, and in rare and severe case, maintenance cyclophosphamide. Rituximab have also a place in this treatment. For acute interstitial lung disease or interstitial lung disease exacerbation, the first question is to determine if there is an associated infection or if the infection could be the cause of this acute exacerbation. So, one should perform a bronchoalveolar lavage when necessary. The indication of bronchoalveolar lavage should be discussed between the physicians depending on the severity of the patient, on the stability of the patient, and on the degree of presumption of the existence of an infection. When the infection is ruled out, immunosuppressive treatment must be started without delay. And the two possible situations is systemic lupus erythematosus acute myositis or the revelation of dermatomyositis with an acute and severe pneumonitis. The first-line treatment is IV steroid pulses as for intra-alveolar hemorrhage, and the second line depends on the underlying disease and on the severity. Regarding chronic interstitial lung disease in children with connective tissue disease, we previously mentioned the frequency of this involvement in connective tissue disease. The diagnosis is sometimes challenging because the child may be asymptomatic for long, and there is a possible underdetection because the peripheral muscular involvement may masquerade the existence of an exercise dyspnea. So there is an importance of the systematic screening by complete lung function test, chest CT scan, and also echocardiography and nocturnal oximetry. Now I will present the international guidelines that were recently published by the ACR and Chest Association. So there are US guidelines, and there are also adult guidelines. It is important to keep in mind that those guidelines are not specific for children, and also it is important to keep in mind that the recommendations are for the majority of them conditional. So in adults, they determine risk factor groups, and the existence of risk factor will determine the frequency and the systematic character of the screening or not. In systemic sclerosis, risk factors are the positivity for anti-SCL70 autoantibodies, the fact to have a diffuse cutaneous subtype, male sex. In idiopathic inflammatory myopathies, the positivity of anti-satetase autoantibodies, but also the positivity of anti-MDA5, anti-KU, anti-PMSCL, and anti-Ro52 are also risk factors to develop an interstitial lung disease, as well as phenotypic characteristics such as mechanic ends, arthritis, arthralgia, and ulcerative skin lesions. In mixed connective tissue disease, the existence of dysphagia and esophageal involvement as well as renal phenomenon is also a risk factor. And overlap features of systemic sclerosis is also a risk factor in mixed connective tissue disease. Once the risk factor group have been determined, the adult recommend to screen systematically for an interstitial lung disease in patients with risk factors, but in the other patients, they recommend to look for a lung involvement only if respiratory symptoms. In the risk factor group, the screening will rely on lung function test and high-resolution chest CT. There is no place anymore for the routine chest radiography. If interstitial lung disease is diagnosed, the monitoring should be regular. Every 3 or 6 months the first year for systemic sclerosis and inflammatory myopathies, less frequently for the other connective tissue disease. And this evaluation should include not only a clinical evaluation but also lung function test. And if one of those evaluations is not normal, chest CT should be controlled. Regarding the treatment, the same group also recently published recommendations for treatment of interstitial lung disease and connective tissue disease for adults. But as we have no recommendation for children, I guess it's interesting to present you those recommendations and guidelines. So as you can see, the first-line treatment of interstitial lung disease and connective tissue disease in adults rely on mycophenolate mofetil, which is the preferred first-line treatment for all the disease. And this treatment should be associated with glucocorticoid at short term for all the disease except for systemic sclerosis, for which there is a strong recommendation against the use of glucocorticoid. If the disease progresses despite this first-line therapy, there are other second-line treatments that should be either added or switched. And those treatments are rituximab for all the disease after mycophenolate mofetil. And in systemic sclerosis and myositis, there is also now a place for anti-fibrotic drug like nintedanib. Nintedanib has the authorization of use in systemic sclerosis in adults and in children. Now it also has been recently approved by the EMA to be used in progressive fibrosing lung disease in children aged 6 to 17 years old. Regarding the association with glucosteroids for the second-line treatment, there is a strong recommendation against the use of long-term glucocorticoid for systemic sclerosis, and there is conditional recommendation against the use of long-term glucocorticoid in the other connective tissue disease. But how to define a progressive lung disease despite the first-line treatment? To this aim, the criteria that are used in adults are the ones that were used in a randomized controlled trial for the antifibrotic drugs, and the assessment is performed on a 24-month period. So progression of the interstitial lung disease will be defined if there is a relative decline in the forced vital capacity of at least 10% of the predicted value. A progression of the disease can be also defined if there is a relative decline in the forced vital capacity of 5 to 10% associated to a worsening in respiratory symptoms or an increasing extent of the fibrotic lesions on the chest CT. And finally, progression can also be defined if there is a worsening of the respiratory symptom associated to an increasing extent of lung fibrosis on the chest CT. Finally, in case of rapidly progressive interstitial lung disease, like the one we presented in this young 17-year-old girl with anti-MDA5 positive dermatomyositis, if there is a rapidly progressive ILD, the adults recommend first to determine if there is a risk of anti-MDA5 positive dermatomyositis. If yes, the treatment relies on IV high-dose glucocorticoid associated to 2 other immunosuppressive drugs that should be started with the glucocorticoid, and those 2 additional drugs are preferentially rituximab and cyclophosphamide. And if there is no risk of anti-MDA5 dermatomyositis, the treatment should rely on IV glucocorticoid, but with only 1 additional therapies. And also, in case of rapidly progressive interstitial lung disease, but also in case of progressive interstitial lung disease that progress despite the first-line treatment, it is important to keep in mind that the patient should be rapidly referred to a lung transplant center for a first contact. So, in conclusion, lung disease in connective tissue disease is frequent in children with the same lung disorder that may be found in adults. These involvements are variable, multiple, and their frequency depends on the underlying disease. In systemic lupus erythematosus and juvenile dermatomyositis, some involvement may be rapidly life-threatening, such as intra-alveolar hemorrhage and progressive interstitial lung disease. In systemic sclerosis, the prognosis is essentially determined by the existence of a fibrosing lung disease that often progresses despite the treatment. Thank you for your attention.